This is actually a tree. A friend of mine from Netherlands who I was at a meeting with a couple of other colleagues several years ago when I talked about the well-being domains, made a tree out of it. And I thought that was a nice little diagram to frame the talk. What I'd like to do in this first part, which is about 45 minutes, is to talk a little bit about where the Eden Alternative Domains of Well-being came from. And as Cheryl mentioned, I've done a lot of work in supporting people living with a diagnosis of dementia. So what I would like to do is to really work this first time on talking about that, because I'm not sure if everybody who is here has necessarily seen or heard me talk about dementia. And because it is so much of what we do now, you know, they say 70% of people living in long-term care probably have some cognitive change. I think it's a good place to start. I'm not going to go through all the arguments about antipsychotic drugs. What I would rather do is just talk about some of the mindset things that I think enable us to find new solutions. And so that's where I'll focus on the beginning. And then when we get into part two after our break, I'll talk a bit more about the well-being domains in detail, and we'll talk about some practical applications. And I'm just going to give some examples, and I'm hoping that you will come up with some examples or stories of your own as well. And I'll finish the second part by talking a bit about life in the COVID era, as Cheryl did, and a few of my observations. I've been speaking a lot about this over the past 6 or 7 months, and hopefully some of my message will be encouraging for those of you who are committed to working with the Eden Alternative and working to improve the lives of elders, because we're already doing some good things that I would like to highlight. So that's part two. I guess I forgot I had a slide about that. There you go. We'll apply the well-being domains to residents and employees, and also talk about the pandemic, and lots of time, hopefully, for discussion as well. So where did these domains of well-being come from? Well, they came from way back around 2005. The Eden Alternative got a grant and supported 10 authors, which included Dr. Bill Thomas and Nancy Fox, former executive director, among others, to write a white paper to talk about the typical quality measures that we have in long-term care. And, you know, the quality measures, of course, are good. It's important not to have falls or not to have infections or long-term catheters that aren't necessary. Those kinds of things are very important, but they are very medicalized. And what are those other things that are important to human life that maybe our quality improvement measures don't capture? That was their original purpose. And they introduced these 7 domains then as a framework for a more holistic approach and said, these are things that everybody needs for a life worth living. But we don't really pay attention to these. In long-term care, we don't pay attention to these enough in society as general. The original focus was on long-term care, though. And I think part of the reason why long-term care often has a bad reputation with the general public is not because we don't have good people working there trying to provide the best care. But I think often people know that these aspects of well-being often get left behind at the door when they move in. And you can have all your medications on time, and you can have perfect technique in helping you with a shower. You can have all the best nutrition. You can have a lovely room. But if you don't have those aspects of well-being, you could still wish you were dead. And so that's where this came from. Since that came out many years ago, the Eden Alternative Home Office and some of their staff started using it to revisit care plans, policies and procedures, employee policies, to say, how can we fit the domains of well-being into some of our daily operations? And about that same time, I started applying them to supporting people living with dementia, and brought it into my Dementia Beyond Drugs class. Cheryl, I believe, was at the inaugural version of that class back in February 2012 in Providence, Rhode Island. And at that time, I hadn't really totally actualized this. I mentioned it, but I know we had at the end of the 2 days, we had an exercise where we had to try to solve a real life clinical dilemma. And I was still throwing a lot of tools out there and not really focusing. And after doing this a few times and people just kind of having their eyes glaze over from all the different things we learned during the 2 days and not knowing how to apply them to the situation, I just said, let's try these domains of well-being. Let's just split people up and apply the domains of well-being. And all of a sudden, something magical happened, which changed the course, changed my approach. And I'll talk about that at the end of this first part. So in the Dementia Beyond Disease version, I did change the order a bit from the Eden white paper just because they made more sense to me in this order. And I felt it would be easier to teach them in this order. And I'll explain that a little bit as we go. But this is the order I use. It's the order I'll speak from. I'm not sure that there has to be an order, but I find that there's a flow when I do it this way. And since you are involved with Eden Alternative, I will share what happens when you put them in this order. And that is that you can line these up as sort of subcomponents of the three Eden plagues. Because if you don't have identity and connectedness, you have loneliness. If you don't have security and autonomy, you have helplessness. And if you don't have meaning, growth, and joy, you have boredom. And conversely, if you're looking for the antidotes to those three plagues, you can find them in those 7 domains of well-being. So they fit so beautifully, and I don't think it was intentional when the group put the white paper together, but they fit so beautifully, and it's not surprising given the people that authored this paper that the philosophy would be so durable throughout this. So what do we mean by dementia beyond drugs? What do we mean by dementia beyond disease? Just a quick overview of what I've done so that we can set that up for the well-being connection. I think that while dementia does describe a syndrome, which is due to a variety of very real diseases or very real injuries to the brain, we have come in my profession and in society in general to view dementia too narrowly as a biomedical disease. And it's not that the disease isn't there, but we're missing the rest of the person. And what happens when we're overly narrow, when we have those blinders on, there's a lot of fallout for the person living with dementia. And that fallout often extends to family care partners, and it often extends to employee care partners as well. So what happens with dementia? Well, there's a lot of stigma. It's hard to overemphasize the amount of stigma in our society around the diagnosis of dementia. We tend to look to pills for well-being because if all we see is disease and if people are upset, then all we see is our solution as pills. And that's how we got into the antipsychotic trap. And it wasn't really ever about antipsychotics. It was about us thinking that any kind of pill was the solution to people's problems. There's a lot of disempowerment because we expect less of people based on our deficit-based view of dementia. We tend to see people narrowly through the eye of dementia care. Over 100 different causes, many different levels of ability, many different backgrounds, races, nationalities, individual personalities, and coping skills, and yet one place to live and one way to care for people. That never really made a lot of sense. I think that may be the biggest misconception in elder care is that this widely diverse syndrome should have one approach. And the other big thing that happens is seeing people's expressions, their words and actions, particularly their distressed words and actions, as behavioral and psychological symptoms of dementia, or what we call BPSD. And this is the area, the mindset, I think, that is critical if we want to truly get somewhere in eliminating drugs, because the drugs were put there by caring people for a reason. They were put in a corner. They didn't know what else to do. If we don't learn to see the world differently, we can take away the drugs, but people will wake up, they'll get distressed again, and what are we going to do? We need a different approach. So let's challenge the BPSD label a bit, because this is what everybody talks about. Doctors talk about it, researchers, Alzheimer's support organizations, the media, everybody talks about this. And so this is a challenge I will send out to you. But before I do, let's just talk about stigma for a second. The biggest danger of stigma is that it causes self-fulfilling prophecies. If you think less of a person, if you expect less of a person, you don't give that person the environment where she or he can perform better. And then when they don't perform better, it just fulfills our expectation that they were incapable. And there's no better story than my good friend Kate Swaffer, a co-founder of Dementia Alliance International, who lives in Adelaide, Australia. Kate had a nursing background, was going to school part-time at night, had 2 teenage boys at home, and she was in her late 40s. I believe she was about 49 years old. It was about 2008, or maybe she was 48 in 2009. I can't remember. But anyway, several years ago, she began having an acquired dyslexia and aphasia, trouble finding words, trouble reading words. She went for a neurologic evaluation thinking she might have a brain tumor or injury or something. And turned out they started doing cognitive tests and they told her that she had a frontotemporal dementia. Now, the way this was presented to her by her doctor was, you have a fatal disease. You need to stop doing all those things because they're too stressful. You need to go home and you need to get your affairs in order. And this doctor also suggested to this woman in her 40s who had driven herself to the appointment that she should start going to a nursing home activity once a week to start getting used to it. So as you can imagine, Kate went into a bit of a tailspin and dropped out. And to their credit, the University of South Australia called her up and said, why haven't you been coming to classes? And she said, well, I have this diagnosis. And they said, well, you have a disability. You have a cognitive disability. We'll give you more time for your assignments. Please come back and finish the semester. So Kate did. She got that second bachelor's degree. She went on to get a master's in dementia studies in 2014. She's published 2 books. She's working on a PhD. She's spoken at the World Health Organization. She's spoken at Alzheimer's Disease International, and she's on their board. I am not suggesting every person with dementia will write books, will get a PhD, will speak at international organizations. But no matter what your path is going to be, we tend to sell you short when we see that label dementia. So when you see someone like Kate, you have to ask yourself, who else are we not denying opportunities to because we expect less? There's one more part about this. The stigma and these self-fulfilling prophecies are institutionalized not only in our care homes, but also in our regulatory and reimbursement systems. Kate, I mentioned, developed problems speaking, problems reading. This was 11, 12 years ago. I've known Kate for about 5 years. And as a doctor, I've never seen her having what I would consider significant trouble with speaking. So what happened? You're not supposed to get better with dementia. Well, Kate tried to apply for speech therapy. And guess what she was told? Probably the same thing you're told in Canada. Certainly what you're told in the US. Dementia is not a qualifying diagnosis for rehab because it's not a treatable disease. If she'd had a stroke, they would have given her speech therapy, but not for dementia. To Kate's great fortune, her neighbor was a speech pathologist and gave her private therapy at home for cash. And that's why Kate speaks around the world. She got better because someone believed that she was not beyond help. And so that shows how we have to really broaden our minds to get beyond this deficit-based approach to dementia. Let's get back to the BPSD now. Another danger of stigma is pathologizing people's behaviors. This is a real ad for Thorazine back from about 60 years ago. Angry man, tyrant in the house, Thorazine can control the agitated, belligerent senile and help the patient to live a composed and useful life. Isn't that wonderful? Now, I would challenge you to say how much have things changed in 60 years? We certainly don't call people senile anymore. We don't use Thorazine much anymore. We have newer drugs, but we use agitation. We use belligerence. We talk about changing people to be more in line with what we think their behavior should be. So let me ask you a little question and give you some examples. Do you think maybe we hold people living with dementia to a higher emotional standard than we do ourselves? Think about what you and I do. We walk, we explore, we get our Fitbits and do our steps, or if you don't like my talk, you get bored and you leave. But if people with dementia do those things, they wander, they elope, although I haven't seen one get married yet, and they exit seek. We get restless when forced into other people's rhythms, but dementia becomes sundowning. We go to a place like Costco and shop in bulk. People with dementia, when they do that, are hoarders. We get angry, sad, anxious, and frustrated because that is human emotion. But if that happens in dementia, it becomes a challenging behavior or even a responsive behavior, some sort of a behavior, which has taken on kind of a pejorative label. That's why I don't even like to use the word behavior anymore. And we don't like being locked up, bossed around, or touched by strangers. But people with dementia, of course, are resistive, agitated, or aggressive. So here's the problem with this framework. By saying it's a symptom of dementia, as a doctor, I would say a symptom is something I feel or express that's due to a disease. So what this framework says is people are crying out, striking out, trying to leave a locked area because their brain disease has caused them to do that. That ignores a host of other factors around that person that are affecting them in daily life. And it pathologizes those things that you or I would do. I don't know about you. We'll get back to this in my COVID section, but if I had to sit in a 200 square foot, what is that, 20 square meter room for 14 days without dementia, I'd be climbing out the window. I don't have a BPSD. If somebody I didn't recognize came in and started taking my clothes off and doing things that they weren't explaining to me, I would probably strike out too. I don't have dementia. And I think that this creates actually a slippery slope. I think this is the biggest barrier to decreasing inappropriate drugs, because if you believe it's a symptom of dementia, of course you're going to use a drug, because that's how we treat dementia. We treat it with pills. And it doesn't explain how drug use has been successfully eliminated. We use a lot of antipsychotics in the US as well, in spite of our initiative to reduce them. But at any given time, there are at least 200 long-term care homes in the US that use 0 antipsychotics and hundreds more that are 3% or less. If these are symptoms of an incurable disease, how did we do that? So this is a little semantic thing, but this is really important. Is dementia the root cause of the person's actions? Dementia is real. And some of the things that dementia causes are trouble retrieving information or memories that help us to understand what's going on and stay in control of a situation. It may impact our verbal communication. It may impact our coping skills and maybe our social filters, so we might react differently than we would have before. And it affects executive function, which is a term for planning and problem-solving skills. Those are all very real symptoms of dementia. As a result, those changes can modulate how a person responds in a given situation, so that it might be different from the way you or I would respond, or maybe the way they would have used to respond. But that's different than saying the brain disease is the root cause. I want to give you a really overly simplistic example, okay? But we're going to start simple, but you can apply this to much more complex situations. Suppose you were to pair up with one of your coworkers and strip that person naked and give them a shower. We've threatened to do this to people. I don't know many people have been brave enough to do that. I haven't been brave enough to do it myself. I have a couple of colleagues that have, like my friend and Cheryl's friend, Dr. Emma Keogh, that has done it. But imagine that you were doing that, and the person who was giving you the shower put the water on you and it was not warm enough. Now, what would you and I do? We would probably say, hey, the water's cold, or we might even reach over and adjust the temperature to our liking. A person living with a dementia who cannot verbalize that, who may not be able to cope with the surprise of being hit by water that's not the right temperature, might scream. That might strike out at you. That is because of what the dementia has done to their brain, the type of reaction. But the root cause was not the brain disease. The root cause was the cold water. And if you believe that that's striking out as a symptom of dementia, you might give them an antipsychotic, but you never turn the temperature up. And you'll never have a good engagement. Now, once again, simplistic, but we'll get into that in a little bit more complex detail. In my experience, and although I started as a GP, I became a geriatrician, and I worked full-time. My office was in large long-term care villages for over 20 years. So I saw a lot of people living with dementia. I worked with a lot of teams, care plans, wellness plans, team meetings, family meetings. When somebody doesn't have something simple, like they've got an infection and they've become confused, I have been able to put the vast majority of people's distress, their words and actions, down to 7 categories. The biggest one probably is unmet needs or challenges to well-being, as we'll see with our framework. Second, sensory challenges, because as we get older, our 5 senses change. And as we live with dementia, our 5 senses can change further. And we need to understand that a person may not be able to filter background noise when they have dementia, or that a person may have less peripheral vision when they have advanced dementia, or that a person under a shower might feel the sensation of water all over their skin as being overwhelming to them because their sensation of touch has changed. So we need to know those things. We may have new communication pathways. We can't say things the way we used to, so we might say them with more symbolic or emotion-based language, or we might express them physically. It could be an expression of agency, just our attempt to control a situation that has become out of our control. It can be a different way of interpreting a problem solving. The brain is still very much alert and working hard to make sense of the world, but we don't have the information. So it may not look right to you or me, but that person is working very hard to make sense of what they can. It could be a response to a physical or relational aspect of the environment, and it could be a perfectly normal reaction considering the circumstances. So I often tell people, if you see somebody where you're trying to figure out what's going on, why they're distressed, if you are told what we are always told in our education, that over 90% of people living with dementia will have a BPSD during the course of their illness, think about where you think the problem lies, what do you think the cause is, and how useful a pill will be. What if instead we were taught over 90% of people living with dementia will find themselves in a situation in which their well-being is not adequately supported? Now, where's the cause? And now, how useful is a pill going to be? There is, my friend Sonia Barsness says, there is no pill that strengthens well-being. How about non-pharmacological interventions? The research on those is not as great as we'd like them to be. And once again, it's not that we're bad people, but I think we're still trying to provide this person-centered care approach using that same biomedical mindset. So what we do is it's reactive. It's not proactive. It may be a discrete activity, but it doesn't have a lot of meaning for the individual. It's a laundry list of things to try, interventions, which might include laundry for that matter. It's not person-directed. It's not tied into individual well-being. And it's even treated like doses of pills. So it might be, hand massage once a day at 3 p.m. Or, pills are used two ways. They're used on a standing dose, so do it every day at 3 p.m., or they're used PRM. When the person gets upset, take them to their room and give them a hand massage. And they'll calm down, sure, but what happens the next day and next day? Just like a pill, PRNs wear off, and you have to apply them again and again because they don't get to the root cause, and they're just superimposed on the usual care environment. And I tell the story about a gentleman I heard about in Iowa who moved into assisted living, what you would call a retirement home, and had significant Alzheimer's and was not able to always express himself verbally. And he kept trying to go out the back door right from day one, and they would redirect him because they didn't want him going outside alone. And he just became more insistent. No matter what activities they tried, he would not attend. And after a couple of days, the manager said, listen, let's just let him go once. We have a fence out there. Let's just watch him and see what he's doing. And he went to the back fence. And as the picture suggests, there was a pasture with cows. And he watched the cows for 15 minutes, turned around, came inside, sat down, and was calm all day. Well, at the care plan, when they spoke with his family, the family said he was a farmer all his life. He probably saw the cows out the window and wanted to check on them. So he was repeating a pattern, long-held pattern from his life. I'm not telling that because they cleverly figured it out or because everybody who's trying to go out the door is trying to check the cows or anything like that. We know that's often not the case. But what do we do when someone tries to do something like this? Well, we might try folding washcloths. We might try music. We might try a hand massage, aromatherapy, and those are nice things. But if you want to check the cows, none of them is going to work because you are not understanding the person and what that person is trying to accomplish. So once again, it's not that it's wrong to avoid pills, but we still have to change our paradigm of exactly how we're going about doing it. Just checking my time, make sure we're doing okay. All right. So the first thing I did with Dementia Beyond Drugs when I started writing the book about 13 years ago was I had to challenge myself, my own profession, what I'd learned about dementia, and say, how can I get rid of the biomedical focus, the stigma, the sort of imposition of my attitudes? I had to go back and strip that away and try to find the most neutral, non-judgmental way I could think of to describe what's happening in the brain of a person with dementia. And I have changed my thoughts a lot over the years. We all evolve if we work at Culture Change. One of the things I love about Eating Alternatives is that they don't have a static approach. They have always challenged themselves to evolve with time. And COVID will challenge us to evolve further. And I will say that I did do a second edition of Dementia Beyond Drugs 3 years ago. And as someone like Cheryl, who's probably seen both books, will attest, they changed a lot. And what I changed most was my own language. I was actually horrified in 2017 by things I had written 10 years earlier, because we do learn and grow as we go. But the one thing that has not changed is this definition. This has been my true north, my guide stone, and that is dementia is a shift in the way a person experiences the world around her or him. And that's all. My experience, my perception of the world is not what it used to be. Although this is going to change too, I guess, because someone in Washington State asked to use permission the other day and reminded me that nowadays even her or him is not good enough for gender identity. So they wanted to use them, and I guess I have to broaden my definition a bit as well. But this road leads down a very different path than we've been going. And one of the first people to help me with this was Dr. Richard Taylor, the late Dr. Richard Taylor, who lived with Alzheimer's for 15 years before dying of cancer 5 years ago. And the first time I heard him speak, he said, "I am not dying of a fatal disease. I'm living with a chronic disability." And that was a huge shift for me, from fatal disease to chronic disability. And when I started thinking of disabilities, I started thinking of people in wheelchairs. We give them ramps and don't expect them to walk upstairs. But no matter where you live, whether it's your own home or long-term care, we take people whose brains and experiences are changing, and we ask them to live in places set up on our view of the world, our rhythms, our schedules, our staffing needs. That's like a stairway. And when they can't accommodate to us, we don't accommodate to them. We medicate them, diagnose behavior problems. It's a path to growth. It's an acceptance of a new normal. And if we can't cure dementia, which we can't, what are those universal human needs that we need to fulfill that we can work on today? Here's a clue. We're going to get back to the domains of well-being. And it led me to challenge, as you saw, how we interpret distress. And so I set as my new goal, not just mitigating disease, but supporting well-being. And that's when I said, let's take this wonderful framework, the Eden Alternative Domains of Well-being, and let's use that from where we go. This is why I think it's important for us to focus first and foremost on well-being. We don't deny there's disease, but we see the illness in the context of the whole person. And, you know, that's where dementia beyond drugs, dementia beyond disease came from. I remember one of my mentors, the late Dr. Frank Williams in Rochester, who was one of the heads of the National Institutes of Aging. His wife, Carter Williams, who was a pioneer in restraint removal in the US, who just died last month and was written up in the New York Times this week. They were such great mentors of mine, and they were visiting me at St. John's Home, where I used to work one day. And I was working on the book, and they asked me about the book, and Frank said, "What are you going to call it?" I said, "Well, I'd like to call it Dementia Without Drugs, but I'm not suggesting that you would never give a drug to somebody with dementia." And he said, "Well, why don't you call it Dementia Beyond Drugs?" And I said, "Duh, okay." And so thank you, Frank. That's one of the legacies of how he influenced me. So it doesn't deny that there's illness, but we're seeing it in the larger context of the whole person. We are destigmatizing what the folks at Schlegel Villages call personal expressions, words, actions, rather than behaviors, and understands that there are other contexts besides just what's going on in the brain. It focuses on achievable life-affirming goals, which I seem to have covered up with my sign, but goals is the last word there. It can bring you new insights like it did me when I started focusing on well-being with my second book, and it helps not only reduce but eliminate harmful drug use. But the most important thing is it's proactive and strengths-based. Most courses you go to on dementia and how to support people who are distressed teaches you interventions that are reactive and deficit-based. A well-being approach can be used for both ongoing support and care. It can be part of your care plan. You can have a well-being plan. And when you talk about alterations in blood sugar or mobility in your routine care plan, you can also talk about identity and meaning and security and say, what are we doing to help this person's feelings of each domain of well-being in our daily practice? Because it's that 24/7 application of these domains of well-being that is the key to decoding distress. And I'm going to give you, just to finish up this section, just a high-level view of how the well-being approach can give you a whole new lease on life when it comes to understanding that hard-to-decipher distress that people have. There's a saying that I like to post in my talks that seeing the glass as half empty or half full is missing the point. The glass is refillable. And so what I have done since I've been working with the domains of well-being is saying, why don't we take those people whose distress is not easy to figure out? They don't have a bladder infection. They don't have obvious pain or something that we can easily fix. But we've been working with it and we haven't got a solution. And we're relying on pills, or we're seeing the person or the people around them suffer and we don't have an answer. Let's look at those 7 well-being domains and let's say, how full are those 7 glasses? How good is this person's sense of identity right now? Their connectedness, security, autonomy, meaning, growth, and joy. And so what I do in my seminars, and I encourage people to do when they see this, is to outline what the person's struggling with, put down what you know about the person, his or her background, and then look at those 7 domains. You can do it in separate groups if it's a class, or if you're a small care team, you can maybe just do this as a group, put the 7 glasses up there and say, how full is each glass based on what we know? Identity connectedness, put a percentage on the glass, 10% full, 40% full, 80% full, and take a look at them. I've done this in a dozen countries on 5 continents, and with really talented, caring staff. It is rare to see a glass, more than one glass that's 30% or more full, and most of them are nearly empty. I can stop right there and I can say, you've done everything you've been taught about helping people with dementia, and here are 7 areas of human need that our system does nothing for. Are you still shocked that your interventions haven't improved things yet? Of course not. And so what we have to do is we have to put that behavior aside and stop trying to fix it. Stop trying to react to it. You may have to react in the moment if someone's distressed, but what we need to do is work in the background 24/7 to fill those glasses. And if you're a small team and you can't work on 7 domains at once, find the emptiest glass and say, okay, autonomy is a problem here. That's why they're having trouble with this shower. What are ways that we can help support this person's sense of autonomy every day, 24/7, with every interaction? Because it's not just about making the shower better. That's part of it. But think of it as the breaking point. When you have no well-being all day, you are like the tea kettle that's almost on the boil. I'm a tea drinker. And so what's the time when you're most likely to be pushed over the edge? Probably a shower, probably being naked, maybe having a stranger that because of rotating staff, something like that. That's when you're going to blow, but it doesn't just mean we have to fix the shower. It means we have to fix well-being all day so that you have resilience, you have reserve, you never get pushed to the breaking point. And so this is what I think the essence is. Now, when I really started talking about this, I'd left my practice. I became an educator going around talking about this. I'm not really a researcher, even though I work with the RIA. So I've been telling people, trust me, this works. I've seen anecdotal responses from my classes. Well, that's not very good. But my friend, Dr. Angela Norman, and her team in Arkansas have finally helped me to see that there is some meat to this. And I want to tell you her story very quickly before I finish up. Angela met with me at the Eden Conference 4 years ago, 2016. And we had lunch together. And she said, I love what you're talking about with this well-being approach. I want to try applying it in Arkansas. And I said, great, knock yourself out. Let me know what happens. Didn't hear from her for 9 months, but at the beginning of 2017, she wrote me. She had gone to a friend of ours who's a provider that has several communities, Eden communities around Arkansas, and asked him to send her to 4 communities that were struggling with antipsychotics. She taught them the well-being domain. She taught them the approach. She taught them how to proactively work that into people's wellness plans. And she wrote me to tell me that after 6 months, 3 out of 4 homes have reduced their antipsychotics by a relative rate of 61 to 71% in 6 months. Of course, my question was, what about the 4th one? Why didn't it work with them? Well, here's the lesson for culture change. And I'm sure Cheryl knows the answer already. What was missing in that 4th home? Leadership. The leaders were not embracing and driving the initiative. Once they got leadership on board, that home had similar improvements. But it didn't stop there. The state of Arkansas, which is a very innovative regulatory group, came to Angela and said, we are going to send you to the top 25 prescribing homes. There's 200 plus long-term care homes across Arkansas. We're going to send you to the 25 highest prescribers. These are the people who are in jeopardy, who are about to be closed down. Take the approach to them. And so a year later, she wrote to tell me, or a couple of years later, that after 18 months with these 25 homes, first of all, 3 of them had closed. Big surprise. They were really in jeopardy. A couple more had had no improvement or had increased. Remember, these are people that were put in enforcement. They were not volunteers. They said, you're in trouble. We're going to shut down your admissions if you don't let Angela come in and do this for you. So these were not motivated culture change folks. So there were a couple of homes that had increases. There were a few that shut down. But you take the 19 or 20 that were left, they had an average of over 40% reduction of antipsychotics in the following year. Once again, the highest prescribers. She didn't stop there. She is now counseling a group of nearly 100 long-term care homes in the state, which all contract with this big group of contracted medical providers, doctors, PAs, nurse practitioners. So they have kind of a closed shop. They can work with these practitioners, and these homes are owned by several large providers. So they can kind of keep some standards, which is really nice because it's hard in long-term care when you got lots of community docs coming in and all have different ideas of what to do. So this was kind of a nice place to try this pilot. They have 92 homes in this cohort. They've been doing seminars, at least before COVID, large group seminars where Angela would teach the well-being approach. They came in, gave instruction. They would have a hotline that people could call if they were struggling, where they could walk them through the process. And as of the end of last year, 2 years into that process, those 92 homes had reduced their antipsychotics to an average rate of 6.5%. That's 6.5% across 92 long-term care homes, only about less than half of what our national average is, even after 8 years of a reduction campaign. Then what they did was they took a cohort of 66 of those homes and they started instituting a protocol that the practitioners would have to go through before they could send somebody out, do what they call in Canada Form 1, or send people out to acute Geri psych units or emergency rooms. So they had to walk through this protocol and make sure they had done all these things before they sent people out. And over the course of 2019, these 66 homes had reduced their discharges to Geri psych units by 75%. And one outlier home that had 12 discharges to Geri psych in the first 6 months of the year went to 0 the second half of the year. Here's the reason why those semantics around BPSD are so important, why I'm not splitting hairs about the dementia being a modulator, but not a root cause of distress. In the United States right now, in their questionable wisdom, the National Institute of Aging has given a $10 million grant to 5 centers, including Mayo, including Harvard, including Emory, to give electroconvulsive therapy to people with dementia who they consider to have severe behavioral disturbance. This is an average of about 12 courses of electroshock therapy for each person. If you think that I'm object to antipsychotics, you can imagine what I think about this. Even in people with depression, where in extreme cases it can be life-saving, there's controversy about how safe it is for a structurally normal brain. You have to wonder with people with obviously damaged structurally brains, how good this is. Plus, if the needs are not met, if it's not just a symptom of dementia, what is the electroshock therapy doing? So the question I would have to ask, because the referral source for these studies is they're having people referred to the ECT study by the local Geri psych units. So my question is, what if those people who are getting electroconvulsive therapy had lived in Arkansas in one of the homes Angela works with? They wouldn't be getting it because they never would have been sent to Geri psych. They wouldn't be on antipsychotics. They would be in a good place because they have well-being. So that's why I think this is important. And that's why I'm so thankful that Angela and Emily and their group have actually put some real practical experience and some numbers behind this so that I can talk about it in a bit more concrete way than I've been able to over the years. I'm hoping that you at Connecting Care will also take up the mantle and generate your own data, generate your own stories, and show how this might work for you.